So the first specimen is a Pura effusion specimen from a 65-year-old female. She had a history of lung adenocarcinoma. So this is her Pura effusion specimen. A cytospin preparation. On low power, we can see there were some cluster of cells, and it shows enlarged nucleus as well as some hyperchromatic feature and scatter around these cytospin smear. So when we go to higher power, so in the background we do see some lymphocytes, some histiocyte, and mesothelial cells. But we do see these tight cluster of cells and showing enlarged nucleus. So you can appreciate some nuclear polymorphism, and this is a three-dimensional cluster, so you need to focus up and down to see clear in every levels. So this is another cluster of cells, so you can appreciate the polymorphism. So this is positive for adenocarcinoma and compatible with the patient's history of lung adenocarcinoma who had the EGFR mutation. And this is the cytospin, this is the cell block preparation. So in the cell block preparation, we can also see there are some glandular cluster. So this is positive for adenocarcinoma. They are relatively scant, but I think if we want to do molecular tests, we can still use this specimen because we do see some tumor cells. So the next case is an ascites, and this is coming from a patient with a history of pancreatic adenocarcinoma. So just on low power, we do not see the normal component. We only see aggregates of these large polymorphic cells. So it doesn't show a two-cell population because most of the cells are cancer cells. So this is quite prominent. We do see these high-grade polymorphic cells arranged in cluster, and we can definitely see some 4-to-1, like a type of polymorphism. They are very big cell and very small cells in the same cluster, and we do see some atypical mitosis, suggests that genome are totally messed up. Yeah, so this is positive for high-grade adenocarcinoma. So next specimen is a peritoneum washing specimen, which is obtained during the surgery of gynecologic, like a total hysterectomy radical surgery from a 50-year-old female who had been diagnosed with endometrial adenocarcinoma by DNC. So we know this is a washing cytology specimen because on low power, we can see large flattened fragments of cells. So these cells are mesothelial lining cells from the peritoneal cavity. And when we do this washing cytology, the entire layer of the peritoneal lining will be falling down, so looking like this. So this is consistent with peritoneum washing specimen. And so usually for the washing specimen, it's quite busy because we do have a lot of cells by the washing force. And in this specimen, we start to identify they were very scattered but highly atypical cells with very prominent vacuolated cytoplasm. But in addition to the cytoplasm, it still show very prominent nuclear atypia. So very big nucleus, prominent cherry red nucleolus, and along with a very like a vacuolated cytoplasm. So these are positive for adenocarcinoma. By the morphology, I'm not so sure whether this histosubtype it is. It can be a clear cell, but it can also be some type of like a hydropic artifact. It is a little bit uncertain. But in this specimen, we do see scattered these large atypical cells, suggest that they were some pleura fluid involvement, not pleura, ascites, peritoneum fluid involvement. So this is positive for adenocarcinoma. So relatively rare for endometrial cancer. So this is a quite unusual specimen. So I think we've seen the case last week. The patient is a 50-year-old female who had epithelioid sarcoma of the foot and with multiple lung and gastric metastases, so relatively uncommon. So epithelioid sarcoma is a sarcoma has a genetic alteration in the SNP-SWIF complex. So here we can do INI1 immunohistochemistry. Usually the tumor cell will show diffuse loss of nuclear expression. So for this pleura effusion specimen, we do see in the background there were a lot of acute inflammatory cells. There were some small aggregates of these round cell with high NC ratio. Usually for the epithelial sarcoma, we would expect to see the cell with rhabdoid feature, a little bit plasmacytoid feature with prominent nucleoli. But we do not see these here. We only see this very small cluster of small round cells. So a little bit uncertain whether this is true metastasis or not. In the cell block preparation, here we start to appreciate that what I just mentioned, that the cell will have a rhabdoid feature and with some eosinophilic material in the cytoplasm and push the nucleus away. And then we can appreciate this cherry red nucleus. So by the histology, this seems to be compatible with epithelioid sarcoma. So we do INI1 immunohistochemistry on the cell block preparation. Unfortunately, it seems to be not working because for the INI1 stain, we want to see every cell show this nuclear expression. So I think it's a little bit uncertain because the background in all these inflammatory cells do not demonstrate a easily appreciable nuclear expression, suggests these are internal positive control. So it is a little bit uncertain whether these clusters are truly loss of nuclear expression. But as we can see, indeed there is some faint expression in the nucleus. So the way that we do cell block here is that we use histogel method. So histogel, we will heat it up, the gel, and it will become liquefied. And then we will mix the sediment with this liquefied gel and cool them down. So when we before we put the gel into the sediment, it is ideal that we will need to have formaldehyde formalin fixation, ideally for more than half an hour, better to be 1 hour or more. So the cell will be fixed before like a contact with the heated gel. So if we have a heated gel, basically it's like cooking. You already cooked the protein, so the protein already degenerates. So occasionally we will encounter suboptimal staining quality due to lack of fixation. So when we do the when we do the cell block, it is better that we put the formaldehyde, and we need to fix the specimen for more than 1 hour. Otherwise, occasionally we will see something like this, lack of internal control, and we won't be able to have a positive result. So this staining is equivocal, but I think cytomorphologically it does show prominent feature of epithelioid sarcoma. So at least we should call these suspicious for epithelioid sarcoma. So the next specimen, this is ascites specimen coming from an 80-year-old female. So on low power, we don't see any aggregates of the cells. However, it does show a relatively uniform monotonous feature with these large individual cells in the background. So when we go to higher power, these cells does show very prominent nuclear atypia, which include highly irregular chromatin pattern. So we have like a irregularly coarse chromatin and with some like a vesicular type of feature. Additionally, we also see prominent nucleoli in most of the cells. So the cell does show these type of nuclear atypia. We do see quite common mitosis in the background. So this seems to be abnormal. And if this is abnormal, this all looks more likely to be poorly differentiated adenocarcinoma. So for this type of individual cell, usually we will pay attention to the cytoplasmic feature as well. For these cells, it does have some cytoplasm. Some of the cell does show a little bit plasmacytoid feature and a little bit vacuolation in the cytoplasm. So this is less likely to be a lymphoma. For the individual cells, we also think about the possibility of lymphoma, but this doesn't look much like lymphoma. So this is most likely to be a poorly differentiated adenocarcinoma. And again, we don't have a two-cell population because majority of the cells here are cancer cells, are tumor cells. So we check the patient's history. She does has a history of gastric adenocarcinoma. So this is compatible with gastric cancer with ascites involvement. So next, we move to the fine needle aspiration cytology. This is a thyroid aspiration. So on low power, we don't see colloid in the background. We see aggregates of cells arranged in flat monolayer sheets, as well as a more three-dimensional, like a papillary type of architecture. We have a little bit of colloid in the background. Additionally, we also see quite prominent multinucleated giant cells in the background. So just on low power, these looks like papillary thyroid carcinoma. So we go to high power to take a look of the morphologic feature. So you can appreciate the cell become oval and the long axes all crossing with each other with more disorganized arrangement. And the chromatin pattern is more like a ground glass pattern. So this looks like a papillary thyroid carcinoma. So we just need to find the pseudo inclusion. So we see a good intranuclear pseudo inclusion over here. So we will sign the case out as papillary thyroid carcinoma. So next is a cytology correlation with histology. So we sent out the case at the beginning of this year. This is a parotid aspiration cytology. So on low power, we see some mucinous material in the background. So when we see mucin material in salivary aspiration, we always would think about, could it be a mucoepidermoid carcinoma? So for the cellular component, we do see nice flattened organized sheets of oncocytes. Additionally, in the background, we do see crashed lymphocytes. So it seems to be a cystic lesion with some mucin, with a prominent lymphocytic background, and with a relatively bland-looking oncocytic epitheliums arranged in these flattened sheets, monolayer sheets, and the cells are all very uniform without apparent nuclear atypia. So basically, we have some component look like a Warthin tumor. So this is non-neoplastic acinar cell. So remember we talked about this yesterday. These all looks like a grapes, a bunch of grapes pattern. So this is non-neoplastic acinar cells. So suggests that indeed this is obtained from the parotid gland. So lymphocytic component. So we have a feature of Warthin tumor. Something is abnormal is that in the background we do see some mucin. So the mucinous component are more prominent in the direct smear. So this is a direct pap smear. So we see some like a orangey material. This is mucin. And in these direct smear, we also have very scant cellular component. So for this cellular component, it does show some oncocytic feature, but some of the cells start to have these more like a spindle shape, suggests that they might be some squamous cells, maybe squamous metaplasia. So another cluster here, again, it does not arrange like a nice monolayer sheets, but more like a whole-like aggregates, and maybe a little bit squamoid feature. So this is the Leusten. In Leusten, we can appreciate the mucin material, some cellular component, mostly histiocytes, suggest that it is cystic. So not many epithelial cell here, but we do see quite prominent mucin material. So basically, our differential diagnosis include benign tumor, Warthin tumor, but it is relatively uncommon to have mucin in Warthin tumor. So these can either be a mucinous metaplastic component, or could it be just Warthin-like mucoepidermoid carcinoma? This is also one of the possibility. So we sign out the case as AUS, and in the report we say this is in favor of a Warthin tumor with mucinous and squamous metaplasia. But we cannot completely exclude the possibility of Warthin-like mucoepidermoid carcinoma. The reason that we use AUS is because we do see unequivocal elements that we can diagnose Warthin tumor, including nice monolayer sheets and the lymphocytic stroma. Something unusual for this case is the mucin, extracellular mucin. So we sign this out as AUS, not SUMP, because we are more in favor that this is a Warthin tumor with mucinous metaplasia. So because of that, the patient received excision biopsy. So in the excision biopsy, we do see for this tumor, nice tall columnar bilayer oncocytic epithelium suggests that this is a Warthin tumor. And indeed, some of these epithelium do show mucinous metaplasia. Hence, the extracellular material have a high content of the mucin. Additionally, we also see some squamous type of metaplasia and with a disassociated squamous cells. So these that we also seen in our specimen. Yeah, something like this here. This is also showing our pap smear. So this is correlated with our impression. Indeed, it is a Warthin tumor. We do see unequivocal bilayer tall columnar cells, suggests this is Warthin tumor, but the tumor does show quite prominent metaplastic change, including mucinous metaplasia as well as squamous metaplasia somewhere. So the final diagnosis for this case is Warthin tumor, and this is correlated with our cytology impression. So finally, we have a pap smear coming from a 52-year-old female who had a history of CIN3 25 years ago with cone biopsy. So this is 52-year-old female. So we have relatively small amount of superficial cell, mostly intermediate cells. So here we can start to see the superficial cell do show nuclear atypia with enlarged nucleus and a little bit coarse chromatin pattern. So this looks like a dysplastic, likely a low CO component. And along the smearing direction, we start to see some very tight, very dark, like a cluster of the cells along the smearing direction. So when we go to higher power, we can appreciate that these cells do show hyperchromatic change. The size of the cells is almost the same as an intermediate cell or slightly bigger. So pay attention to the size of the cell. Usually for the low CO, the size of the nucleus would be very big. But for the high CO, the size of the cells are usually smaller. So along the smear direction, we see these aggregates of the cells. So we can call these hyperchromatic crowded group. So are these squamous cells? Are these glandular cells? And so we just need to decide. So I think the cell do show some squamous differentiation. So you can appreciate it's mostly oval. And but indeed, the cytoplasm is not very distinct. It's not a very dense cytoplasm. But along the smearing direction, we see these cells throughout the smear. So which means that there must be a focal lesion and sampled by the smear. So I have to say, some of the cell cluster do show a little bit feature that it's suspicious for could it be a AIS, because you do see they are a little bit like a stratification, maybe a little bit glandular feature over here, maybe a little bit like a luminal border here. But it is not certain. So I think this is likely high CO with prominent like endocervical gland involvement. So here again, you start to appreciate that these stratification could be the feathering type of changes in the AIS, but we do not see any unequivocal feature of AIS. So usually if you have difficulty to decide whether this is squamous or this is glandular cell, you just find the area that you feel more comfortable that this is either or. So here, I think everyone can agree this looks more like a squamous cells, not a glandular cell. So for this case, we will call this high CO. And because we do see superficial cell also with a typical change, and this spindling morphology is more consistent with a squamous morphology. So if we do see high CO component, I think majority the component will be high CO, and these are likely represent glandular involvement of the high CO. For this particular case, the lesional cell are quite abundant. This is a lot of these cells throughout the entire specimen. So I think it's we also need to consider, could it be like a superficial invasive, micro-invasive squamous cell carcinoma, because we see a huge amount of these high CO cells. But in this specimen, we do not particularly see a prominent tumor diastasis pattern. However, I think this is a little bit suspicious for a tumor diastasis. So I think for this case, there is just the background feature looks like high CO, and we do suspect that there may be some glandular cell involvement because of the glandular type of arrangement. And additionally, because the amount of the cells and the small clumps of the cellular component that may suspect they might be a superficial invasion. This might be a microinvasive squamous cell carcinoma. But overall, for the smear, I think the best diagnosis for this case is high CO. And high CO is sufficient for the clinician to do the subsequent management of the patient. So we will call this high CO. And for any case that we call high CO, we need to trace back 5 years to see if they are prior smear in our institution. And for this case, there is no other smear in our institution. Okay, so that's all the case for today. Thank you.